Prof.Bancha from Thailand. I'm talking about the meniscus root management. I'm from Thammasat University Hospital. This is my hospital, close to the Don Mueang Airport. So you can visit us anytime when you come to Thailand. So this is a committee of the ASA yesterday. Thank you for invitation and congratulations and great rubies for the new president of ASA. We will support you. So everyone happy yesterday, okay? We are very happy. Everyone have a new couples, right? Except these two guys, yeah, they have their own couples. So they are very, very happy, right? So meniscus root tear actually is quite common. It's quite common. It's about 33%. And in the past, we missed it because we thought that this kind of patient is like osteoarthritis, early arthritis. It's the most common diagnosis, okay? And the tear site is always very common at close to the root, close to the medial root. Lateral side also happen, but it's common in ACL injury. It's totally different group. Medial root in elderly, in middle age. Lateral root is common in ACL injury. Okay, so this is the medial lateral root. Okay, injury. So you see that there's a gap. The middle root there's a gap, but lateral root there's no gap. I will tell you why. Okay, if the root torn, then you have like you have total meniscectomy, the peak contact pressure also contact area, same like total meniscectomy. So this is the root. You need to remember the anatomy. This is medial, this is lateral. Okay, this PCL, okay, medial meniscus root is here. You can see. Okay, when it's torn, is there will be a gap, and meniscus will extrude. Lateral root is totally different because lateral root there is a Humphrey and Risberg. Okay, connecting the lateral root. That's why lateral root never have gap. They just float from the tibia. Okay, so it's very close to the PCL. So this is a classification by Dr. Rabrat about the root tear. So we will say root tear if the tear site is close to about 9 millimeters. The most common type is the type 2. This is type 2 tear. Most common. It's a complete tear within 9 millimeters from the attachment. The classic clinical presentation is normal X-ray, medial joint line pain, and this pain is so painful. If you ask the patient, you have any injury? They say, no injury. But think carefully. So, oh yeah, I squat. The very common is squat in the toilet. Squat in the toilet. I think in Indonesia you need a lot of squat, right, on the floor by praying. So you have tear. It's like a minor injury. Sometimes you miss the step when you go downstairs. So that is a very common injury. It's not serious like ACL. No hematoma, nothing, just pain. Okay, the common pain is here, post-low medial of the joint line. Okay, X-ray look normal, but you need to recognize. If you have this kind of patient, you need to send patient to MRI. Otherwise, you miss, and finally you turn to arthritic chain within 5 years. So the classic MRI is number 1, that's marrow edema. See that? There's white signal on the tibia, sometimes on the femur. Number 2, you have ghost. Number 2, there's the extrusion, means that extrude, kick out of the joint. And you see lateral, you see ghost. Ghost means disappear, right? Ghost. Ghost sign in the section that next to the PCL section. The last one is a cleft lip, cleft palate, right? So there's a gap between the PCL and the meniscus. So this is a 4 classic sign for the meniscus root tear. So if there's still acute, the marrow edema, extrusion less than 3 millimeters, no joint space narrowing, this is a good indication for repair. But if you're too late, you cannot repair. This is the result of the repair. You see, extrusion can be reduced, ghost side disappear, and meniscus can be healed. Okay, it depends on the timing. So this is one of the patient has root tear and delay. So that also can happen at the femoral side. You look back to your SONG patient, spontaneous osteonecrosis. You look back, many of these patients have meniscus root tear, and sometimes they have happened also at the tibia. This is one of my Japanese patient, she squat on the floor. She has no trauma, but Japanese style need to squat on the floor, right? So she has a vascular necrosis on the femoral side. So the Post-op, you can, if you reduce extrusion, the result should be good. But if you're too delayed, you cannot reduce the extrusion. So option can be conservative or surgical treatment, partial meniscectomy or meniscus root repair. Like Danny said, we tend to save the meniscus, okay, nowadays, because we know that meniscus is very important. In elderly, this is the good indication if the patient is old enough and they have not so much problem, we conserve like we do at the patient arthritic change. So this is a good paper, 5 years. Okay, the progress to be type 3 also tried this. Okay, indication for repair is the patient that have root tear, acute or chronic without arthritic change. So the technique is number one, you need to release because this area is quite tight. Okay, because patient don't have good ACL, good PCL, so the joint is always tight. So the way to do that, I use a needle number 18. Going just above the joint line in this corner, you see? After you make this, I release at the POL, you can see the lesion. Okay, that's why many times we miss it because we cannot see the posterior part of the knee joint. So increase, using this percutaneous is quite useful. And also the way to repair, we prove that the way to do that is the modified Kessler stitch. So I showed you, this is my article published with Dr. Dinan. Okay, so this is a meniscus root tear, it's just folding. You make a drill hole. So this kind of procedure, you can use the meniscus stitch, repair from the tunnel. Okay, so most of the time you do it for the lateral side because lateral side is always attached, not so much gap, and you can repair it from the tunnel. So in this situation, you don't need to release the MCL, see? And then we make like a Mason Allen stitch, okay, for the repair. So finally you get this picture, okay? This we call the transtibial tunnel suturing technique, okay? And the technique, this is a technique nowadays we use, okay? First you need to make a raw surface on the tibia, this is PCL, okay? Aiming device, do the tunnel, okay? Pass the suture in, we can use like a suture passer, okay? Pat this in. So the way we do that, we do like Mason Allen. Okay, first we make a stitch on the root, like a cinch, and then we pass in a suture, different colors, and pass this into the tunnel and suture to the post. Okay, this is the way we do the meniscus root repair. So if the joint is very tight, and sometimes you don't need to release the MCL, you can come from the back. Especially in the meniscus extrusion to the back. So you can make 2 tunnels on the posteromedial, pass the suture in, and then we can make a tunnel from the back. Pass this suture in, and you make a drill hole. Okay? Everything doing from the back, so don't have to release the MCL. Okay? This is another way we do nowadays. Okay? Because sometimes it's very difficult to get through. Whenever you don't release, you make a cartilage injury because you try to go to the back of the joint. So this is another way to make a postural medial. Or you can make hybrid, especially when you make hybrid, make a tunnel here from the back, make a raw surface, okay? And then you make a tunnel from the back. And then pack this suture in, okay? So I told you, you can do it in many ways. You can do from the front, you can do from the back also, okay? And pat this suture into the tunnel, and then suture the post. And another thing is you have to be careful when you tie to the post, not do it too aggressive. In the past, I do too aggressive, tie to the post, so the result is cut through the tissue. Just tie to the post, okay? Do not make aggressive tying the knot. So the result of the repair is about 60% of the healing. For many literature, vary from 0 to 60, but the one article from Dr. Kim, his article is 90%, but most of the article is not that good because of the chronicity or delay diagnosis. Okay, and problem is the extrusion is only 50%. You can repair, sometimes heal, but extrusion still occur. Whenever extrusion occurs, that means the meniscus is still outside the joint. Result should not be so good. Okay, and they still have progressive cartilage arthritis. So this is the lateral side of the meniscus. It's totally different. You have the wrist bulb, right? So lateral never have the gap. You just float. So lateral side is easier, much easier. You just pat the suture in because release bulb is protect the meniscus from retraction. Okay, and pass this suture and make a drill hole. So we always, you look back, a lot of ACL patients that have severe pivot shift, looking for the lateral root. Also, this is another patient. You see, it's float. Okay, and we did the same way. Okay, pat this in. Okay. So this is I told you if you have the good, the gap is not so big, the result should be fine. So another thing, if you have this is too late to repair. You see, the joint space start to narrow, and you see the gap is too big. This is a good sign. So this is another way. We need to do osteotomy, right? This patient just repair doesn't work because the joint space start narrow. So this is the way we do extrusion reduction. Okay, we do the all inside. We put the anchor in and reduce the extrusion by making a knot. Okay, reduce the meniscus back, and then we can do the meniscus repair to the PCL. Okay, like this. Okay, do the same in the upper and lower part of the meniscus. So, because if you make a transtibial tunnel, the problem is you have the tunnel of the screw will merge into your tunnel. Screw jam to tunnel. Another way is you can do this way, this osteotomy. You see the cartilage is gone. Okay, you can make a transtibial, but careful, screw can injure your suture. Okay, so we make all inside repair using the fast fix with this way. Okay, so this is another study that report from Rinaldi, my good fellow. He's from Bandung. He did the report of the 3 tunnel repair. This patient have ACL and also medial lateral root tear. So this is a recommend tunnel to make it not jam. Okay, for the root repair bilateral. So this is the results after the repair. Good. And this is a new concept of meniscus root repair because now we cannot solve the problem. Only 50% have extrusion. So that's why we propose a new tunnel to reduce the meniscus root by making a transtibial reduction. She's my mother, this one. Not this one, this is my wife. Okay, this is my mother. Don't confuse. My mother have knee pain for 3 years. You see, right knee. Left knee look worse than right. So I said, no problem, mother. I inject the viscose cement for you. But finally, 3 years later, the knee changed to be arthritis like this. The left knee is still the same. So when we do the total knee replacement, you see that just a meniscus root tear, also the radial tear. So that is the happened to me. This also happened to me. This is my good friend. Yeah, he is around here. You know him very well. Okay, this guy. Yeah, he thought he's still young. He run in Bali. Okay, and he has a meniscus tear, radial completely, extrusion also. See, now he can come back to dance with the ladies. You see. I try my best to reduce the meniscus back. This meniscus looks so ugly. Finally, it's get back, and also I reduce the extrusion for him also. Okay, that's happened to me. And this is the last thing. This is a new idea we call the meniscus root reconstruction. We use a cancellous tendon to reduce the meniscus back because using the suture sometimes is not healed because cartilage. Okay, you use the allograft, gaseous graft to reduce the meniscus back. Okay, so take home message: you need to know the root anatomy, high suspicion in the patient, actually middle age with medial joint line pain. Look X-ray normal, and in lateral meniscus, severe pivot shift. Should thinking about the lateral root tear. Okay, happy to see you. Happy to see my ex-fellow, good fellow, sexy fellow, smart fellow, and this is the naughty fellow. Good, and we love batik suit yesterday very much. We will support our new president, Dr. Andy Lupis. And please come to Thailand. In 2019, we have the meeting on the beach. Also 2020, very important. We have APCAS meeting in Thailand. Save the date, please. Thank you.